Check 1, 2. Morning, ladies and gentlemen. May I please request all of you to kindly settle down? Please take your seats as we shall be starting the conference. May I request everyone to kindly quickly find a seat and settle down? On behalf of APPI, it gives me great pleasure to invite you and welcome you again to the second annual conference of APPI 2015. Thank you all for being here. I hope you had a great evening last night. And we're looking forward to an exhaustive yet exhilarating conference for the whole day as well. I hope you've got your energy all packed in. Before I do start on the first speaker, I know we're running a little late, but a couple of housekeeping messages. May I please request all of you to take out your mobile phones, pagers, beeping devices, put them on silent mode. This is for the integrity for the speaker who's going to be here conducting the session and for your fellow colleagues who are going to be here, and so that you don't disturb anyone here. So please put them on silent mode or switch them off entirely. May I also request all of you to refrain from walking during the session is on. It's disturbing for the people sitting next to you or in the same row as you, and before and after. So please make sure that you refrain from walking during the session. Also, we'd request you to not kindly ask or look for question answers round within the session. Please look for the speaker or the person who's taking the session outside and take your questions offline. During the breaks and lunch is what we recommend. A couple of other housekeeping messages. For your certificates, the workshop certificates will be available at the end of the day at the registration counter, so please make sure that you collect your registration certificate, your workshop certificates at the registration counter at the end of the day. For those of you who are living or staying here residential at Leela or Lalit, I'm assuming that you've either checked out or you will be checking out before the stipulated time by the hotel. Any additional days that you want to stay would be borne by you. Payment receipts for the registration are also available at the registration counter. We'd like you to meet with Rohan and collect your receipts for the same. I'm hoping that there's been no inconvenience for your stay here at Leela or the Lalit, but in case you've been inconvenienced, we duly apologize, and we hope that we'll make the rest of the day a lot better. APPI membership forms are also available at the registration counter, so if in case you're interested, please make sure that you look up for Rohan and look at APPI membership forms that are available at the registration counter outside. All right, ladies and gentlemen, time for us to start for the first session, and without further ado, may I please invite on stage Dr. Sukesh Nair, who will be taking a session on platelet function assay. He's a DCP, DNB, and MD in pathology from CMC Vellore and was awarded the State Gold Medal. He's completed fellowship in hematology from the Royal College of Pathology in Australasia. He has been involved with laboratory quality assurance programs for our country and has influenced the practice of laboratory hematology and immunohematology in India to a great extent. He holds prominent positions in several reputed organizations. These include Chair, Laboratory Science Committee, World Federation Hemophilia, Chair, IEQAS, International EQAS, World Federation of Hemophilia, Chair, Accreditation Committee, Medical 112203, National Accreditation Board for Testing and Calibration Laboratories, NABL, to name a few. Ladies and gentlemen, please give him a round of applause, Dr. Sukesh Nair. And before you start the session, Doctor, to felicitate him, can I please invite on stage Dr. Ajit Zambekar to come on stage and kindly felicitate him before we start the session. Dr. Ajit Zambekar, could I please have you on stage? Your first session is going to be for about half an hour, 30 minutes. Dr. Sukesh Nair. Thank you, sir.
Thank you very much. Nice to be back at the APPI in Mumbai. Of course, special thanks to Suvin Shetty for inviting me again. So today he has given me a topic not very popular among hematologists because not many people do it, is platelet function assay. But I'll try to see how I can bring you closer to what you could do in your laboratories. This is a cartoon representing a normal blood vessel where all the coagulation factors are going in a normal fashion, they are all inactive. There is platelets, there are von Willebrand's factor, they're all in circulation. And the issue is when there is an injury, what happens? All these coagulation factors, including along with the blood, they flow out at the site of injury. And just imagine if the injury was at the arterial side, the flow of these particles would be really, really fast. So something has to hold these factors and platelets to the site of injury, to the collagen, so that they can actually start binding, get activated, and form a clot. And just to highlight that, you can see the platelets going with the flow of blood. We know that platelets have an affinity for collagen, but who is going to hold the platelets to the collagen, especially if it's an arterial bleeding? And that is done by this great man, von Willebrand's factor. Von Willebrand's factor by itself, single moiety itself, a large protein, 2050 amino acids compared to alpha globin or beta globin, which is 141, 146. One moiety of von Willebrand's factor is 2050 amino acid, and it circulates in the blood as 20 to 40 units together as a multimer. But in the blood, it is rolled up, and trying to hide the factors which attract platelets. So all the active part of von Willebrand's factor is hidden inside the rolled part of von Willebrand's factor. And what is outside the von Willebrand's factor is actually the part which got an affinity for collagen. And we know that collagen is usually under the subendothelial cell and only will be exposed when there is injury. So when the von Willebrand's factor is circulating and finds exposed collagen, the parts of von Willebrand's factor moieties which have an affinity for collagen will start binding to collagen one by one, so that it rolls out like a carpet and exposes the binding site for the platelets. Now these platelets are in going out along with the flow of blood, suddenly find something it likes, tries to bind, but when it's trying to bind, the flow of blood takes it away. But every time it tries to bind, it is able to resist the flow of blood, so that finally it has got enough resistance to stay put and bind to von Willebrand's factor and get activated also in the process. So just imagine if the von Willebrand's factor had not multimers, by the time the platelet develops resistance to bind, it goes off. And it's one of the most common types of von Willebrand's disease, where the high molecular multimers are absent. So now you have the platelets which are adhering through its glycoprotein 1b receptor on A1 part of von Willebrand's factor, gets activated, releases procoagulants material within it, which attracts more platelets, activating those platelets, and then these platelets bind to each other through glycoprotein 1b, 2b3a and fibrinogen, leading to platelet aggregation and forming the primary hemostatic plug. And this is primary hemostasis. Of course, these primary hemostatic plug actually requires further binding by cementing fibrin, which of course they form a good platform to allow. But we are now focusing on platelet function test, and the physiology that we need to handle is only up to this particular stage. So laboratory evaluation of primary hemostasis or platelet function is required when you have a patient with a history of bleeding. And of course, cardiologists and neurologists want to find out the efficacy of the antiplatelet therapy. And of course, to identify whether the patient who is going for procedure has a risk of bleeding. So that is when people order for laboratory evaluation of primary hemostasis. So screening test for primary hemostasis would involve very simple platelet count, bleeding time, because bleeding time looks at all the aspects that we just now saw, the platelet addition, the platelet aggregation, and the platelet secretion. And of course, a little activated partial thromboplastin time, because we know that in von Willebrand's disease, factor VIII is decreased. But please remember, the most important diagnostic test in the field of bleeding or hemostasis is history. An abnormal coagulation test, whether it is a bleeding time, a PT, or an APTT, has no major diagnostic value if the patient is not bleeding, has not been a bleeder, there is no past history of bleeding, and is not likely to be a bleeder because there is no family history of bleeding, or the patient is not on any medication that puts him at the risk of bleeding. So this is platelet count. You know that platelet counts are done by machines. You can do it manually in your lab. Recently, I was at a CME for postgraduates. I asked the postgraduates, what do you think of cell counters giving platelet count? Do you think it's reliable? Nobody answered. So I asked, do your teachers and professors tell you that platelet counts are unreliable on the cell counter? Everybody said yes. No. So I said that I am now going to teach you why cell counters are the most reliable tool for doing platelet counts. Because you are only looking at the count. Look at the histogram. The histogram will tell you, and the cell counter is warning you that there is an abnormal population present. Please look at the smear. and ultimately, finally, you look at the smear, and in the smear, one platelet is equivalent to 15,000 platelet per cubic millimeter. And the advantage of looking at the smear is not only to verify the counts, you can also identify abnormal platelets. For example, you have this low platelet count with large platelet, which is called as macrothrombocytopenia. And when macrothrombocytopenia is associated with bleeding, you can call the patient as Bernard-Soulier syndrome. In Vellore, we have an entity called macrothrombocytopenia because Vellore handles 8,500 patients on outpatients every day and 2,500 inpatients. 30% of our patients come from the eastern part of India, and 1 in 8 of them have got macrothrombocytopenia. Many of them being referred even for being treated ITPs, having bone marrows. But they are actually normal. They are not bleeders. So this is an advantage of looking at the blood film because you can identify macrothrombocytopenia. And of course, you can also easily identify conditions like May-Heggelin. Yesterday I was taking a workshop, and I promised the people that I will show off my staining capabilities, which I do in my lab. We do a modified right Giemsa. My Romanowsky stain is beautiful. You can see the neutrophils having the Dolly bodies. They are so beautiful. Getting this reproduced is not easy, and you can see the large macroplatelets, and you see the cytoplasm is so bluish. You see the bluish cytoplasm and the granules. So platelet morphology is so beautiful after we have modified our right Giemsa. So this is a May-Heggelin anomaly. You can see the inclusions in the neutrophils. So apologies for the people who who came to the workshop that I didn't put up this slide. But I think if you want to show off something, show it off in front of a large audience. Bleeding time. Bleeding time is the time taken by a standardized skin wound to stop bleeding. What is a standard skin wound? Standard skin wound depends on the tool that you're using to make the wound. So here in Vellore, we use a simple lancet where the blade is 3 millimeters deep and 1.5 millimeters wide. There are blades which are available in the world called Simplate and Template, which are trigger-based devices which can make wounds. But one Simplate will cost about 600 rupees, while this is only 50 paise. And we have published the authenticity of this particular method, which is modified IVIS method. So the modified IVIS method is trying the BP cuff at 40 millimeters of mercury to equalize the venous return, select an area avoiding any veins or angiomas, clean the volar aspect, stab confidently 3 times, and start the stopwatch at the end of the 3rd wound. Now, why 3 times? At least one wound would be a standard skin wound. Now, obviously, it depends on who is going to make the wound. Now, please remember, this wound is not a prick. It's a stab. So if you are trying to make a wound with a needle, it's not a bleeding time. You have to stab. You have to stab with a blade, and this blade is a lancet. The other blades that you have, Simplate and Template, is also blades, but one wound would be enough because that always makes a standard skin wound. So in our lab, we have got 64 technologies working, of which only 4 of them are allowed to do bleeding time. So that is very important. You have to keep in mind. So disadvantages are it's time consuming, there is operator variability, it's invasive, difficult to standardize. It's very difficult to get 20 normal people who want to get stabbed 3 times to establish a reference range, and insensitive to mild defects, and there is no specificity. So this was when I was going to Australia in 1999. I went in 2000 to do my fellowship in hematology. PFA 100 had come, and everybody in Australia were writing articles and churning out articles, and I actually went to the lab who churned out the maximum articles on PFA 100, Emmanuel Favaloro, and that Westmead Hospital. So PFA 100 is a point-of-care device to assess the platelet function in whole blood. It basically is a device which has got a cartridge a reservoir into which you add the blood, and this reservoir is connected to this reservoir with a larger reservoir, onto which a suction is applied. So when the suction is applied, the blood in the reservoir is sucked in to this through a capillary, and this capillary is mounted by a membrane which has got an aperture. This membrane is coated with collagen. So when the blood is being sucked in at a high shear, the von Willebrand's factor and the platelets will start aggregating, blocking this aperture, and then you have the aperture closed. So the end point is called the closure time. So when I went there, they said bleeding time is no longer good. The time to start the test until the platelet plug occludes the aperture is called closure time, and closure time is the indicator of platelet function in the analyzed whole blood sample. So they said it requires only small amount of blood. It's very simple with proper training. Anybody can do it. It's a quick test. Anybody can do it in 5 to 10 minutes. No real operator variability. You can standardize it. You can establish a reference range. And they said the initial publication was telling it's very sensitive to mild von Willebrand's disease, very sensitive to mild platelet function disease. In fact, when I did my vivas for my exams, they showed me a situation where the bleeding time was more than 20 minutes. They asked what is abnormal. I said type 3 von Willebrand's disease. They said what is abnormal. Then finally I said, you want me to, because all registrars were made to tell, or they were told that bleeding time is a bad test, PFA 100 is a test. So I said, I know you want me to tell that bleeding time is a bad test, but in my lab, bleeding time is a good test. So they asked me to come next year for the Viva again. But whenever a new tool is developed, it has to be evaluated by a standards committee in the ISTH, International Society of Thrombosis and Hemostasis, and they found that studies showed that it can miss mild von Willebrand's disease. Just to speak a few words about utility of bleeding time in severe bleeding disorders, among 852 patients who came for primary hemostatic defect in our place 2004 to 2008, the sensitivity of IV's method was 100% for Glanzmann's, 85% for Bernard-Soulier, 68% for mild platelet function defect, and 63% for von Willebrand's disease. So if you look at my type 1 mild von Willebrand's disease, 52% is not bad. But please remember, I only make 4 people do bleeding time. So in developing countries, most of the people who come to hospitals are having severe bleeding disorders. And bleeding time is a good screening test, provided it is done by standard reference method. And the method that I showed you, I modified IV's method, anybody can do it. But a lot of training. The site has to be, the standard reference method is, it should be lateral 1/3 of the forearm, 2 to 3 centimeters distal to the antecubital crease in an area devoid of hair, scars, tattoos, bruises, surface veins, infected skins, moles, or other lesion. The direction of incision should be uniform in a lab. I would recommend parallel to the antecubital crease because that is sensitive to aspirin as well as mild platelet function defect. Blot from the sides and not on the top, and only a fewer technologies and more so the experienced one should perform with 2 to 3 incision. And if you follow this, your bleeding time is going to be a reliable test. But, so therefore I didn't buy a PFA 100 when I came back from Australia. Now, look at my data of 2012 and 2013. I have, this is about 750 patients who come to get evaluated for bleeding disorder, increased bleeding tendency. And the other one is, the next data is 2013. Around 700 patients come. And if you look at it, of course, I can make easy diagnosis in all these cases, but I have got this, and this. This, there's a platelet defect that's identified. The patient has got bleeding. We give a diagnosis, but we don't know what that platelet disorder is. And therefore, the PFA modified their machine. They came out with PFA 200, and I decided, okay, maybe this PFA 200 will help me identify some rare platelet disorders, because I work in a place where there's a lot of autosomal recessive disorders being seen because there's a high degree of consanguinity. You saw the list, I've seen I see almost 40 to 50 Glanzmann's thrombocytopenias every year. So you can see that I see a lot of rare disorders. So probably these rare disorders are never seen in the world, and they've never been described. And we describe what others have described. Maybe it's time for us to describe some rare bleeding disorders or rare platelet disorders. Now, this PFA 200 that has come, which is different from PFA 100, has got an extra cartridge which is specific for P2Y, and I got the device mainly for patients with increased bleeding tendencies. And it has really helped me because if you look at the bleeding time data, this is about last 6 months data, 44 patients on whom we did evaluation for bleeding time, 8 of them, the bleeding time was normal. And these 8 patients were type 2 von Willebrand's disease, and there's a reason for that, because this test is done in high shear, and high shear will only pick up type 2, while bleeding time cannot pick up because it is low shear. Acquired platelet dysfunction with eosinophilia, it was totally missed, but that's because, again, the same philosophy as high molecular weight multimers being absent. Acquired von Willebrand's disease, also the bleeding time missed. Mild platelet function defect, also the bleeding time missed. And in the PFA, only P2Y was abnormal, indicating that possibly this patient is an inherited P2Y12 receptor deficiency. But of course, we have to do molecular work to identify that. So now this instrument is very popular in our department because we can discern certain patients by screening test. This is a screening test that they could have a bleeding disorder. But this instrument, after it came, it has become a big headache for me because what has happened is the second day of this instrument, one of our VIPs of our CMC council, he got admitted. He was on full-blown antiplatelet agents, but developed a vascular event. And I think his family, who was in the US, they said that he was not being cared for properly. His antiplatelet agents were probably inadequate. So immediately the cardiologist asked me, can you do a test where you can say the platelet function? So I would have done a platelet aggregometry. But then I said that I've got this tool if you want. So when we did the test, the platelet, it immediately showed that he was completely, fully antiplateletized in his body. So he was having full antiplatelet action. So that made the cardiologist very happy. And in fact, the relatives in US also said, oh, you have a PFA, so we can trust the result. After that, this cardiologist and his team, they send me samples, plenty of samples. And that is the reason it's got a headache. For example, 42-year-old male, acute myocardial infarction, planned for PTCA. He's loaded with antiplatelet agents. So he has been given a loading dose of 600 milligrams clopidogrel and 300 milligrams aspirin. And now they want to send the sample for evaluation of the effectiveness of these two drugs. So we do the usual aggregometry. ADP shows 60% response. That means there is a decrease, and ADP is only 60% rather than 100%. Arachidonic acid is 60%, and thrombin is 110%. That means they are normally functioning platelets, but ADP and arachidonic action because of aspirin and clopidogrel has been suppressed. We also have a flow cytometry tool called VASP, which is a gold standard for clopidogrel assessment. And of course, we had the PFA 200 by that time. So VASP is a vasodilator stimulated phosphoprotein. It's a protein on the platelets, and it's expressed in high levels in platelets. It is usually unphosphorylated at basal state, and usually prostaglandin and nitrous oxide will phosphorylate it, inhibiting platelet aggregation. We know that nitrous oxide inhibits platelet aggregation. ADP promotes dephosphorylation through P2Y12, and thienopyridines inhibits the P2Y12 receptor and therefore negates the ADP's inhibition of VASP phosphorylation. So this assay is done on the flow cytometer. What we do is we expose the platelets to ADP and prostaglandin. The prostaglandin will phosphorylate. ADP will try to overcome the effect of prostaglandin under test condition for dephosphorylation. And we are trying to see whether the clopidogrel grievin has some action on this. And the flow cytometry measures the amount of phosphorylated protein using a monoclonal antibody, and that is expressed as MFI. Case 1, it is not 100%, it is reduced, 56%. Desirable is less than 30%, more than 50% is classified as not responding to clopidogrel. So if you look at my aggregometry result and the flow cytometry VASP result, there is some effect, but it's not complete. There is not complete effect. I do the PFA 200, it shows total unresponsiveness. All the results are within reference range. So, I'm probably 2 months into this machine, but of course I know the literature on this machine. So I call up the cardiologist and says, this patient is not responding to your antiplatelet agents. So he immediately asked me, what should I do next? What am I to do? He's a cardiologist. He's given antiplatelet agent and he's asking me, based on the result I've given, what do I do next? He's asking me. And I said, I asked my colleagues, what do I do next? I can't do anything. So what do you do next? If you are in that place, what do you do next? We are all laboratory hematologists. So a laboratory hematologist will look at the blood film. So we made a blood film. Because, I don't think so that was the answer, but, when you are lost, the first thing you must do is make a blood film. And this is what we saw in his blood film. He had these large platelets, which were rich in, bluish cytoplasm, deep blue cytoplasm. Normally they're grayish in color, and a lot of granules, which we call as large young platelets. And these large young platelets have got a deep blue cytoplasm and rich in azurophilic granules. And these young platelets contain a lot of mRNA. And like reticulocyte contains mRNA, and they look little different on your Romanowsky stain, they call as polychromatophilic red cell. Similarly, young platelets will also have a deep blue cytoplasm, and they are called as reticulated platelets. And this can be picked up as your immature platelet fraction. And this patient, you can see the immature platelet fraction was 44.2%. Now, what is the significance of that? Young platelets contains residual mRNA, which can translate in peripheral blood, expressing many of its proteins. So now, for example, this patient has been given aspirin. Aspirin's effect is very short. In 2 minutes, it will block the COX-2. But this mRNA will produce more COX-2. So aspirin, till the next day aspirin is given, his COX-2 is going to be active. This mRNA will produce P2Y12 receptors. So clopidogrel that acted at that time, you have to wait till next day before the new new P2Y12 receptors are suppressed. So this patient was producing COX-2 and P2Y even in his platelets, And studies have shown that mRNA, the platelet, immature platelet fraction or reticulate platelets can contain up to 9,500 transcripts of mRNA. So this fluorescent dye identifies that in the IPF. So then after seeing this result, we called the clinician and said, don't increase the dose of your aspirin. Rather than that, you give aspirin, same dose, once in the morning and once in the, so BD dose instead of OD dose. And actually, immediately after that, we started going to the literature, and there's a beautiful article written by Paul Harrison, aspirin twice a day keeps a doctor away. So that is mainly because of this thing. So actually, we can give an opinion to a cardiologist. So when you get an abnormal screening test, you need to do specific tests, and specific tests would be platelet studies or von Willebrand assays. And platelet assays, confirmatory test is through platelet aggregation, and still the gold standard, LUMI aggregometry, flow cytometry, and electron microscopy. So platelet aggregometry represents one of the most widely used test procedures for assessing platelet function. There are two main types of instrument, an instrument which can do all three, that is light transparent aggregometry, whole blood aggregometry, and LUMI aggregometry. But there are also instruments which can only do whole blood aggregometry based on impedance. Just like briefly look at them. The optical aggregometry can show you a lot of patterns, reactions that you have on the platelets. That's why it still remains the gold standard compared to other methods. Aggregometry is nothing but a spectrophotometer which has got a transmitting light and signal that's picked up. So platelet-rich plasma, usually prepared by light centrifugation from citrated blood, it will be turbid because it is kept in suspension by a small stirrer, and therefore the transmittance will be minimal. This transmittance is recorded by a graph, and when you add an agonist like ADP, epinephrine, collagen, and ristocetin, the platelets will get activated by agonists, they aggregate, the stirrer cannot hold them up, and they settle down and clear the plasma, allowing more light to pass. So if platelet doesn't respond to the agonist, they remain suspended and do not transmit light. So you can see that the agonist is added, the platelet will change the shape, so therefore the turbidity increases, and then slowly you can see the primary response and secondary response with ADP, epinephrine, a delayed response but full response with collagen, and a good response with ristocetin. So this is the aggregometer we have, chronolog. This is the cuvette with the stirrer bar, and this is the principle of the transmittance, just a spectrophotometer with transmittance aggregometry. So this light transmittance aggregometry gives a lot of pattern, shape change, primary wave aggregation, secondary wave aggregation, allows us to identify platelet function defects. So the agonists that we use are strong agonists and weak agonists. Strong agonists are collagen, thrombin, thromboxane, and weak are ADP and epinephrine. So here we have a patient who has no response with ADP, epinephrine, and collagen, but a small response with ristocetin. We know that patient is likely to have absence of glycoprotein 2B3A, and that's Glanzmann's thrombocythemia. When you have a patient who responds with ADP, epinephrine, collagen, but no response to ristocetin, which basically means that either the von Willebrand factor is defective or the platelet glycoprotein 1B is defective. We do differentiate between them by adding normal plasma, which has got von Willebrand factor, and if it corrects, aggregation corrects, that means this patient has got severe von Willebrand disease, and one who does not respond is Bernard-Soulier syndrome. And this is another pattern that you can see in other aggregometers, so I just put that up here. This is Bernard-Soulier syndrome. The same aggregometer can do impedance aggregometry, which is basically in the whole blood, which is done in whole blood. If you add the agonist, the platelets get activated and they bind to the electrode here. Once they bind to the electrode, the transmittance between these electrodes will stop, and that is recorded as a resistance in aggregation. And this is what you see there. And it's a good tool. It's more sensitive for aggregation effects of ristocetin. Sensitivity is better than optical in effects of aspirin and dipyridamole. It's not dependent on optical characteristics of the sample, so therefore you can do it on any sample, whether it's lipemia, hemolysis. And as centrifugation is not required, it is better with giant platelet counts when giant platelets are increased. And this is another point of care or near patient testing device, multiplate. This is also based on impedance aggregometer. So you can do further confirmation of Glanzmann's by doing flow cytometry, release of ATP, ADP content, confirming the heterozygous state of the patients, and you can also realize that only small quantities of blood are required for flow cytometry. And electron microscopy will identify deficiencies of granules that you can have in some of the patients with gray platelet syndromes or dense granule deficiency. And if you are able to identify the molecular defects, you can offer antenatal diagnosis. So after this, you can develop an algorithm where you can identify these disorders. Now, I work in a place where I see these disorders, and I can assure you that inherited platelet disorders are very rare. What is more common are acquired platelet disorders. So, it's very like until unless you've got a good hematologist in your working setup who can identify rare inherited platelet disorders, it's a good idea that you can set up platelet function testing. But what about, we know that inherited platelet disorders are very rare. So, showing you the algorithm is not fun, but sometimes you may be coming across this patient, 10-year-old child with easy bruisability, gum bleed since 1 year, and previously asymptomatic. So, a 10-year child, whether he's got an acquired bleeding disorder or